Good morning or good evening, everybody. Today we will talk about biology and kinetics of solid tumors. It is very important subject. There are a lot of theoretical things, but we will concentrate on things which can be translated into a clinical practice. As you know that tumors are defined by a growth and the proliferation of cells is due to the presence of certain stimulus, in brackets, carcinogens, and usually the growth and the proliferation will continue even the stimulus is ceased or stopped. When a normal cell transforms into a malignant cell, it loses some characters and it gains some other characters. If you have the chance to see malignant cells transformed from benign to malignant cells, if you have the chance to see these cells under the microscope, you will find that those cells having the malignant characters are variable in size and shape and variable in staining ability, and there is an increase in the nucleocytoplasmic ratio. That means that the nucleus is enlarged and on expense to cytoplasm, and the number of nucleoli increases and the number of mitochondria decreases. Usually, tumor cells, either they will be well differentiated and they have lot of normal characters, but if they are present in abnormal place, it is considered to be malignant, even that the under the microscope appears as normal. And this is a typical example for this is the differentiated thyroid carcinoma metastatized to the lymph nodes. If you take a biopsy from the lymph node and you didn't mention from where the site of the of the biopsy, the pathologist will tell you that this is normal thyroid tissue, but it is not taken from the thyroid, taken from a lymph node, so that this is considered to be as a metastasis. Usually, as we mentioned, that there are certain characters are lost from the cells, and there are several behavioral changes occurring in the malignant cells. One of these things is the cohesion abnormalities. As you know that in normal tissue that the cells are attached to each other and they're difficult to be separated from each other. But in case of malignancy, usually the cells are repelling each other and they are not strongly bonded with the other cells. And this will facilitate some of these cells will escape from the site of the tumor and to go to distant metastasis. This cohesion abnormality is due to decrease in the intercellular cement, which is composed of polysaccharides and the glycoproteins, decrease in the number and the function of desmosome. Those are usually microfilaments attaching the cells together, and usually there is loss of contact inhibition, so that if the cells proliferate in normal situation, when the cells facing each other and comes in contact with each other, usually the growth and the proliferation of cells is stopped. But in case of malignancy, it is not the case. Usually, the cells are continuously grow without any contact inhibition. Also, the normal cells having a negative charges along the surface membrane of the cell, but this negative charges is increased in case of malignancy. This is due to accumulation of larger amount of certain structures like sialic acid, phospholipids, glutamic acid, and aspartic acids. This make the cells like a magnet. If you bring two magnets and put the similar poles opposing to each other, they will repel each other. But if you bring the positive pole with the negative one, there will be a strong bond between the two magnets. Also, the cells usually continue to proliferate in case of malignancy. If we have, for example, these cells in this plate, those cells usually can divide until they make a one layer of cells, okay? And then in normal situation, it will stop. And if some of these cells are lost, usually the nearby cells or stem cells will replace these removed cells, and after the balance between the removed and the normal cells or the developed cells cover the defect, there will be no further proliferation, so that this phenomena is under the control of the body by different mechanisms. And we will refer to this slide later in the presentation. Usually there is behind the formation of cancer is a genetic hypothesis. The genetic hypothesis says that one cell at one time succeed to transform from benign to a malignant cell, so that the malignant cells coming in any type of cancer is monoclonal in origin. Usually, the most direct cause for malignancy or normal cell to transform into malignancy is a damage to the DNA. And in 90% of the cases, the damage to the DNA is acquired, and it is due to different exposures or several exposures along a period of time to certain carcinogens, like chemical carcinogens, like physical carcinogens, like biological carcinogens, etc. In 10% of the cases, the genetic damage is occurring in utero due to the hereditary problems rather than to unacquired problems. In this slide, you can see how the normal cell progress into a malignant cell, and this is called a multi-hit theory. Suppose that we have a normal cell here, and it is exposed to a carcinogen. There will be some sort of of DNA damage in this cell, and the fate of this cell, either it will die by process of programmed cell death or apoptosis, or the corrective mechanism happened to this, removed the genetic defect and replaced by a normal structure of DNA. And sometimes in the third scenario, that the cell itself will continue to have the genetic damage, but it will divide several times. And by the continuation of this carcinogen, usually the cells, when they start to proliferate and carrying the genetic defect, this will lead to mild dysplasia. And this mild dysplasia, probably the cells are surviving without a problem, and they are capable to grow and to proliferate. With further exposure to the carcinogens, usually there will be the malignant cell, those cells in mild dysplasia phase, they will come into a severe dysplasia, and this is a step just before the malignancy. The difference that in all of these steps is under the control of the body, but here you find that after having the severe dysplasia, there will be a tumor, and this tumor is now it is out of order, and it is not responding to the inhibitory mechanism or death from the body itself, so that in this way that the tumor are developed by multi-hit theory. Usually there are regulatory genes, regulatory genes, and those genes are either promote growth of cells. We call them growth promoting genes, and those are actually a normal genes having a normal function related to growth and proliferation, but it is under the control of the body. But when there is some sort of mutation of these cells, they are trying to produce growth factors, different growth factors, and this will enhance the formation of cancer. So that for this reason we call them growth promoting genes. And we have a growth inhibitory genes, That's to say that those cells, that those genes are capable to deal with changed cells, genetically mutated DNA. Those cells, they are trying to suppress the continuation of the malignant process, and those are recessive genes, and they suppress the formation of cancer. Usually, proto-oncogenes are activated and called oncogenes, and those have a normal function. This normal function is due to cell growth, controlling of cell growth, and gene transcription. While tumor suppressor genes, when they are in normal situation, in normal function, they cause DNA repair. If there is a damage to DNA, they will make a DNA repair so that they can reverse the malignant process, and they can control also the cell cycle phases. And it is responsible about the cell death when those cells are genetically defected, and usually there is a mechanism of programmed cell death guided by those suppressor genes. If these genes are mutated so that we will lose their function, and usually this will favor the formation of malignancy. One of the important genes is the p53 gene, and this gene is a protective gene. This gene normally responding about the cell cycle arrest and apoptosis in response to DNA damage. Usually, this gene is implicated or has a role in the formation of cancer in more than 50% of the different types of cancer, and it is located in the chromosome 17. The other two important genes, they are the BRCA1 and the BRCA2 genes. Those are suppressive genes. They prevent the formation of cancer, but usually they are located in the chromosome 17 and the chromosome 21, BRCA1 in chromosome 17 and BRCA2 in chromosome 20, chromosome 13. BRCA1 usually responsible when it is mutated. It is responsible about the formation of breast cancer, ovarian cancer, prostatic and colon cancer, while in a BRCA2 mutation, usually this will favor the development of male and female breast cancer, ovary, prostate, pancreatic, and laryngeal cancer. 5 to 10% of breast cancer is familial, and a mutation of these genes account for 80% of familial cases. Function of the we mentioned the function of the tumor suppressor genes. Now, suppose that we have this cell transformed from benign into frankly malignant cell. It starts to divide into 2, and the 2 into 4, and the 4 into 4 by 16, and so on. And this is called an exponential proliferation of cells. Most of the people thinking that the tumor cells are growing more faster than the normal cell, and this is actually not the case. There are certain tumors, they are rapidly growing, but the majority of the tumor is having a slow process of development, especially in a preclinical stage. And there are in our systems that we have faster, we have normal cells proliferating more fast than the malignant cells, like the bone marrow cells, like the fetus itself. Usually the fetus originating from fertilized ova, which is a one single cell. After 9 months, it produces a baby of 3 kilograms and a placenta of 500 or half kilogram. So that this is a very huge number of cells proliferating over the short period of time. This curve giving you a difference between the benign and the malignant cells actually. Once, if in normal situation, when we have some sort of cell loss, Usually, the body will respond by cells to proliferate until there is an equilibrium between the cell loss and the cell birth, and the condition will continue in a steady state. In contrary, the malignant cells continuously proliferating without any purpose. Okay, the malignant cells are rapidly proliferating for a while in the preclinical stage, but when the tumor is large, usually the cancer cells or the cancer size is decreased, and this probably to different causes. Some of them lack of oxygen, lack of nutrients, and usually trauma to the cells from the nearby cells. This is an important diagram. If you have the chance to see a tumor between your hands, all of this tumor is not composed of malignant tissue. Almost half of this tumor composed of non-malignant tissue, and the other half composed of malignant tissue and malignant cells. The non-malignant part provide logistics to the tumor cells, like the blood supply, the vessels, the lymphatics, the fibrous tissue, fibrous skeleton, and some other logistics. And you can see also some immune cells within the tumor itself. Those are supportive structures for the tumor to survive. If we take the portion of the malignant portion or the proliferating portion of this tumor mass, we will find different types of cells. We have what's called the clonogenic cells or stem cells, and usually those are in a quiescent situation. They are sleeping cells, and when it is necessary, they can go into proliferating cells, and when the growth is need to be inhibited, some of these cells will return back to the stem cells. We have other types of cells. They have a severe genetic problem, so that those cells, they may be capable to divide once or twice, and after that they will die. We call them doomed cells. The clinical importance of this, in case, for example, in testicular cancer progressing to the retroperitoneal lymph nodes, making a retroperitoneal mass. And when we apply proper treatment by chemotherapy, for example, we will find that not all of the mass disappeared, but there is a residual defect there. But this is actually, it is not a malignant tissue, it is a healed tumor tissue. We can say this. If the patient having tumor markers initially before the treatment, still when you still find a mass and the markers are returned to the normal, it means that those are non-malignant structures of the malignant mass. This curve showing it is called Gompertzian curve. As you see that if you plot the size of the tumor against the time, we will find initially the tumor is rapidly proliferating because most of the cells of this tumor is a growth fraction. Okay, those are the proliferating cells, and with time usually there is a slowness of the tumor progress due to decrease in the percentage or the ratio of growth fraction in comparison with the other types of cells. What is the importance of this? It means that if you catch a small tumor here, like in case of micrometastasis, and you give the patient chemotherapy, usually there will be almost 100% response. But if you give a chemotherapy in this stage or in this period of time where the tumor is big, usually the number of the tumor will not disappear by chemotherapy, and usually there will be an inherited resistance for the chemotherapy of some cells and acquired resistance due to the chemotherapy. Again, if as we mentioned, if we have a plate like this, and we have a group of cells, and we provide these cells by a growth promoting factors, it will continue to proliferate until making one layer. By adding other growth factors, it will continue to proliferate to make another layer. Actually, these promoting factors, they are growth factors, like platelet derives in a growth factor, insulin like a growth factor, vascular and endothelial growth factor, and other growth hormones. Um, if you, as you see here, if we provide the quiescent cells into with the proper growth factors, it will start to grow and to proliferate. This is a normal situation, but in case of malignancy, that these growth factors are secreted from the cells, from the malignant cells itself. As you see here, and we have number of cells here. Some of these cells are secreting growth factors, and it consumes the same growth factors to proliferate. This is called an autocrine effect, and these growth hormones can go into nearby vessels and promote them for growth and proliferation, and this is called paracrine effect. And we have an autocrine effect, that the growth hormone coming from the pituitary gland stimulate these cells. The clinical implications of this, for example, that we can reduce these growth factors actually by certain biological medications, and this may lead to arrest of the growth and the proliferation of cells. Another example, that if you, this is a stomach diagram for a stomach. If we have a perforate, if we have a peptic ulcer disease in this area, and we apply the proper treatment for this ulcer, usually there will be healing. The cells adjacent to the at the edge of this ulcer, they will start to creep to fill the gap of the ulcer, and the patient will be cured from his peptic ulcer problem. But if the patient having malignant ulcer here, this malignant ulcer, the malignant cells will secrete hormones like transform growth factor alpha, which lead to the continuation of the growth and the proliferation of cells, and this cannot be stopped except by excising this portion of the stomach, or applying chemotherapy or radiotherapy or another modalities which proper for the treatment of such types of cancers. As we said, that tumors not always are growing very rapidly. This curve, we are plotting the number of cells against the number of years. For example, if we have a one malignant cell, to be 1,000 cell, it needs 10 doubling time. Okay, that doubling time, it is the time needed for the tumor to double its size. Okay, this is called tumor doubling time. And with further proliferation by 20 doubling times, usually we will develop a mass of a tumor composed of 1 billion cell, of 1 million cell. And usually in case of size, it is almost 1 millimeter in diameter, or 1 cubic millimeter as tumor mass. With further doubling, in 30 doubling time, usually we will have 1 billion cell. And usually at this stage, most of the cancers giving symptoms and or can be detected by different studies like imaging studies, or by taking biopsies. And usually the dotted part of the tumor, as you see, probably it is 4 to 5 years occurring in a preclinical stage, and after that it will reveal itself and it becomes in a clinical stage. We call it a clinical growth, and this is a latent period which is unlikely to detect a tumor in this when it is in the small number of cells, like 1,000 or 100 types of cells. So, in summary, we need 30 doublings time for a tumor to be of 1 centimeter, of 1 cubic centimeter, or 1 gram of tissue. Okay, and usually at this stage we are capable to diagnose most of these tumors. And if there is a continuation of a growth of further 10 doubling, so that it means 40 doubling times, the tumor it will be 10 to power 12, or a weight of 1 kilogram. And in this situation, that the host cannot uh, tolerate this tumor burden, and usually it is not compatible with life. Also, regarding the theory of development of tumors, the most studied tumors is the breast cancer, being the most common cancer affecting females. And there are two theories about the formation of the tumor and the progression of the tumor. And based on two theories, there are different types and development of the management of the tumor itself. For example, that a tumor here in small size in silent period, it is less than 1 centimeter in diameter, half centimeter, or 1 millimeter in diameter. Usually it will grow until reach a size, and then from its index site, for example, a tumor in the breast, okay, then after it is clinically appear, it will go into the lymph nodes, and from the lymph nodes, it goes to make distant metastasis. This is called Halsted theory, actually, and based on this, that the management of cancer, according to Halsted theory, that you have to remove the whole tumor and the potential lymphatics around. It means that you have to remove the whole breast tissue, you have to remove the pectoralis major, you have to remove the pectoralis minor, and probably to do aggressive axillary dissection. In spite of doing this aggressive treatment, still with the studies, with the follow-up of the patient, we find many of those patients usually they have recurrence of the disease. So that this is not an ideal theory to use for the treatment of cancer. The second theory is that when the tumor in a preclinical stage, or it is very small, it can shoot metastasis to the lymph nodes, or directly it goes to the distant metastasis. For this reason, the people who believe in this theory, that they said that that breast cancer is a systemic disease from its beginning. Actually, the fact it occurs between the Halsted and the Fisher theory, so that this depends on biological characters of the tumor. Some of these tumors are aggressive and they should metastasize early in the course of the disease, and for this reason we give the patients chemotherapy, assuming that we have micrometastases in other parts of the body, like lung, like liver, like the bone, so that the use of chemotherapy, which is called adjuvant chemotherapy after removal of the tumor, reduce the chance of systemic failure or distant metastasis. So that there is no theory fitting the whole biological process and the development of the tumor. Each tumor has its own personality and has its own character, and it is different from one person to other. Usually we have to talk about the cell cycle. Cell cycle is important because there are what's called checkpoints, and these checkpoints recently can be blocked in order to prevent continuation of the or progression of the cycle for the sake of division. We have quiescent cells, as we said, and those called in G0 cells. Those are sleeping cells. They are not proliferating, but when it is needed for any reason, usually the quiescent cells, they will go from G0 into G1, and the cells start to accumulate RNAs and proteins, okay, during this phase until we reach the S phase. The S phase is the phase of DNA synthesis beside the RNA and the protein, and we have the G2, okay, It is also a pre-mitotic phase called pre-mitotic phase, and usually continuation of protein and RNA formation beside the established formation of the DNA. And we will have the mitosis, where you know that there is a spindle nuclear chromatin spindles which can be separated into X-ray spindle rays. Uh, the importance of this, sorry. Okay, the importance of this is it has something to do with the chemotherapy. Some of the chemotherapeutic agents they work on different types of the cycle. Some of them they work on specific phases of the cell cycle. The last thing we will talk about the metastasis. The metastasis is the whole problem of any cancer. If there is no metastasis from the cancer, usually it can be treated locally and there will be no problem. But usually the cancer usually recurring after even a long time. And usually the cells are migrating from the from the original tumor. As you see that this tissue, those are malignant cells developed in the within this tissue, and those malignant cells they can survive if they are small in size. It is if it is 1 or 2 millimeters, they can survive by imbibing nutrition and oxygen from the surrounding structures. But once it is there is a growth and development of the tumor, it needs to do its own blood vessels, so that you can see that the tumors initiating vascular endothelial growth factor, and they make their own blood vessels here, and those blood vessels usually they are not so compact and not so good like the normal vessels, and those vessels they are weak. They can, some of these cells can detach and it goes into the lumen of these blood vessels, uh, and while it is in the blood vessels, usually the malignant cells making a what's called a embolus, and usually the malignant cells surround themselves with fibrin, with platelets, so that the malignant embolus will increase in size and it will escape into the circulation until as you see escaped into the circulation here, and what's doing what's called malignant embolus, and it will go through these vessels and until it is impacted here, where the size of the embolus more than the diameter of the tumor, so that they will stay here, they will adhere to the wall, and they start to escape from the inside the blood vessels into the surrounding tissue, and they will start again doing shows by process of angiogenesis in new blood cells. The last thing we will talk about, that perfusion is very important to supply the tumor by nutrients and oxygen. Some of the cells they can survive for, if they are of 1 or 2 millimeters in diameter. The newly formed cells they can secrete these types of growth hormones to grow and to proliferate, and usually it will go the metastasis, the cells are going everywhere, but there are selected sites for the metastasis, for the for the metastatic cells to be hosted in certain organs. So the common organs that the tumor is go to is the liver, it goes to the bone, it goes to the lung, but it is rarely going to the spleen, rarely going to the myocardium or the skeletal muscles. So that there is a theory called soil and seed theory. The seeds are the malignant cells, but they need the proper soil for them to grow and to proliferate. That's all for today. Thank you very much for listening.